colleagues and participants. Welcome to the plenary session 3rd of today's international seminar. My name is Shakil Ahmed, Research Scholar, Department of Sociology, MANUU. I would like to invite the chair of the session, Dr. Sheila Surya Narayanan, to the dais. Now I would like to introduce the chair, Dr. Sheila Surya Narayanan, professor at the Center for Women Studies, University of Hyderabad. She holds a multidisciplinary academic background in geography and development studies, University of Pune, and did her PhD in public health from Queensland University of Technology, Brisbane. She authored the critically acclaimed book, A Transnational Feminist View of Surrogacy Biomarket in India. Her work has influenced national policymaking. Her contributions were cited in the Rajya Sabha Select Committee on Surrogacy and incorporated into India's Surrogacy Regulation Bill. She also presented her research at international forums, including the United Nations in Geneva, and participated in global discussions on gender, reproductive justice, and surrogacy in cities such as Rome, Paris, Vienna, Stockholm, and New York. She also led the establishment of GIS laboratory at the University of Hyderabad, supported by GIZ. In summary, Dr. Surya Narayanan is a leading scholar in feminist public health, reproductive justice, and women's environmental and occupational well-being, shaping academic discourse and contributing substantially to policy and practice in India and beyond. Without any further delay, I would like to invite Dr. Sheila Narayanan to chair this session, and I hand over the session to respected ma'am. Thank you, ma'am.
Thank you very much. That was a rather longer introduction than what I had given. I think it's Shahida's work. Thank you very much. So I would invite the speakers. Amiti Jasroti, Dr. Rashmi Kumari, Professor Sudha Kakhote, Bhushita Sharma, Srinivas Kodali, and Nimisha Sidhu. Welcome, and I'd start straight. I think we have about 10 minutes each, and then we have some time for discussion each. So I look forward to your presentations. Should we start with Dr. Amiti Jasroti, the Srotia, and Dr. Shikha Jagarwal. The topic is Gendered M-Health, Adoption and Inequalities in India's Public and Private Healthcare.
Okay. So, good afternoon, everyone.
Yeah.
So, at the outset, I would like to thank Professor Shahida, Seminar Director, Dean, and Director for Center for Women Studies, and a friend, Ziauddin, Head Department of Sociology, and all. Today, I will be presenting findings from ongoing study, which is actually still going on. It's a working paper, which is titled as Gender M-Health, Adoption and Inequities in India's Public and Private Healthcare. It actually trying to explore how gender shapes the use and adoption of mobile health technology. So I'm thanking you all here to listen this particular presentation. So today I will be presenting this particular research, especially focusing on access and usage with a special focus on the Indian context, The study is grounded in a qualitative exploration conducted across public and private health facilities in Jaipur, Rajasthan. And we have analyzed through multi-theoretical sociological lens too, as I'm coming from the sociological background. But before commencing, I would like to extend my sincere congratulations and gratitude to the organizers for conceptualizing such a forward-looking and timely theme. When we look at very title of this seminar, it reflects the deepening complexity and gravity of the issues at hand. Traditionally, scholars and academics within the field of gender studies are primarily engaged with the question of gender. You can see the title that it has been extended up to the digital. Earlier, it was, just the politics of gender and then health, and then now we are talking about digital initiatives. So, however, with the advent and rapid expansion of digitalization, it has become increasingly important to examine its multifaceted impacts, both positive as well as negative. Since we are listening from the morning and discussing these particular issues, that how we are developing in this particular area, what technology is doing us, and how the digitalization is, getting into the realm of gender. So in particular, the influence of digitalization on health, especially from a gender perspective, warrants critical inquiry and reflections. So with this, I start my paper. I had divided my whole presentation into 3 parts. The first one is contextual framework. This section will explore the broader context of gender and digital inequities, particularly as they intersect with health systems and digital health interventions. The aim is to critically reflect on how structural disparities shape access, engagement, and outcomes in the integration of technology within the healthcare. The second part is key questions and sociological lens. I'm drawing from the sociological perspective, and this segment will raise key analytical questions concerning power, access, and social norms. These inquiries are essential to understanding how gendered experiences shape interaction with digital health technologies and their implications for equity and inclusions. The last stage, which is still going on, but I will share some inputs from my field, research setting and some analytical focus. This part will outline the empirical settings of the research and examine how the interplay between gender, health, and digital infrastructures benefits in practice. The focus will be on identifying patterns and linkages that illustrate the socio-technical dynamics shaping health outcomes in digitally mediated environments. Health, as we know, is fundamental to human development, but in many parts of the world, including India, access to healthcare services remains uneven distributed, especially along gendered and intersectional lines. The rise of digital healthcare through mobile applications, telemedicines, wearable technologies has transformed how individuals engage with health services. Mobile phones are becoming ubiquitous and increasingly an important tool in global health programs. Although mobile phones have the potential to connect clients with healthcare providers, provide new avenues of delivering information, optimize data collection, and facilitate healthcare worker training and communication. However, as we are listening again and again, the transformation is not gender neutral. Despite low-income countries making rapid advances in mobile phone access, a gender gap persists in access to mobile phones among men and women, which may exacerbate inequalities in access to health information. Differentials in access to mobile phones among men and women are estimated to range from 2% in Latin America and East Asia, 14% in Sub-Saharan Africa, to 26% in South Asia. Further, among women that do own a phone, usage patterns are significantly lower than men's, particularly in the use of text messages and internet services. So there is a big gender gap, and I'm going to present some stats and visuals to ponder upon. Globally, women spend 25% more of their lives in poor health than men. It is the report by World Economic Forum 2024. And if we look upon India, only 33% of women have ever accessed the internet compared to 57% of men. And this is the report by UNFPA. While the global gender report indicates a marginal improvement with the gender gap globally, closing from 68.4% in 2024 to 68.8% in 25. In India, where mobile penetration has reached approximately 70% of the population, mHealth represents a particularly promising vehicle for democratizing health services. Mobile ownership is similarly skewed. Women are 20% less likely to own smartphones, and even when they do, their usage is often restricted by family norms and surveillance. And according to UNICEF, only 41% of women in developing nations have internet access, compared to 53% of men, and women are 20% less likely to own a smartphone. In India, this divide is more pronounced. Just 33% of women have ever used the internet, as compared to 57% of men. So these disparities have material health consequences. Without equitable access to mHealth platforms, women's autonomy in health decision-making is severely promised. So if we look upon the sociological lens, so I have included the sociological lens, which highlight power dynamics, social structures, and healthcare inequities. Feminist theory in particular critique how mHealth can reinforce patriarchal norms, portraying women mainly as caregivers or overlooking their specific health needs, especially sexual health. So Judith Butler's idea of gender performity, Donna Harvey's cyborg concept highlights the interaction of gender and technology. It shows how mHealth integrates with gendered bodies and identities. Again, we have also tried to look from the SCOT framework, which is a social construction of technology framework, which examines how gender factors shape users' priorities in India. Popular fitness apps, for example, Fitbit, Google Fit, Samsung Health, focus on general wellness metrics, activity, heart rate, sleep, while offering limited or no content on sexual education, STI prevention, or contraceptive guidance. So conversely, mHealth apps targeting women emphasizes menstrual and maternal health, often reinforcing gender assumptions by prioritizing reproductive care over broader health needs like sexual health, mental well-being, or occupational stress. In addition to it, we also included Anthony Giddens' structuration theory, which offers a lens to examine the dynamic between individual agency and structural constraint in women's adoption of mHealth technology. If we look upon the urban and educated context, women increasingly using mHealth tools, such as maternal health apps and telemedicines, demonstrating agency in accessing healthcare. But in rural areas, usage of government-sponsored apps, which is actually their own tool, only tool like e-Mitra or Arogya Setu, often facilitated, which is actually facilitated by ASHA and A&M interventions, similarly empowers women to make informed health decisions. However, patriarchal norms, low literacy, limited digital access, and socioeconomic barriers continue to restrict mHealth use. For example, male preference in smartphone access or cultural stigma around technology limits rural women's participation. So with this, to go further, we have also tried to see all the findings through one ecological model, that is Brenner's ecological system model. This present also tries to visualize from this model. So this is a valuable framework for analyzing how multiple layers of social and environmental context influence human development. So we can see from the, that is not just. So this is the model which we have incorporated to visualize our findings. In the center, you can see the women. which is actually the number of factors, interplay when we see the women. That is age, education, literacy, reproductive health needs, awareness of mobile technology. So all the models, it is a layered view of how macro to micro system impact access. So after this, we have microsystem, which is actually the closest environment. For example, family norms and expectations like caregiving roles, husbands or in-laws control over phone use, household decision making, for example, permission to own or use a phone. Peer influence, for example, family, friends, or neighbors' mobile use. Then we go up, then we have to see, we are able to see that there is another system which is called as mesosystem, which is actually the interconnection between microsystem, which interact between household and healthcare workers. Community health outreach and digital support, for example, NGOs or ASHA workers, which encourage mHealth app use. Then again, if we go up and we are able to see there is another system which is actually indirect, but having very influence, which is institutional. This is called exosystem, which we can see in the form of mobile network coverage in especially rural areas, cost of devices, data plans, spouse workplace digital exposure, local health programs promoting mHealth. Then there is wider cultural and social norms, which is coming under a macro system, which is called as patriarchal gender roles and digital control, cultural norms discouraging female autonomy, caste, class, and religious ideologies around technology. So with this, I'm not going to explain this, because we have also tried to find out the link between the aspects and its impact on health. So I'm coming exactly to the leading questions, and this is again the one paper which is very, very important to understand the mobile phone access among women and its impact on healthcare engagement. This paper is showing that when the mobile phone access, coming easier to women, then there are some improved care seeking practices and kind of improvement we are able to see in women's scenario. But there are some leading questions when we able to see this. First, the gender disparity in mobile phone ownership is not only pronounced, but also contextually variable, with significant differences observed across geographical regions, socioeconomic strata, and cultural settings. This variation reflects the complex and uneven nature of digital access globally. Second, this gap is shaped by entrenched social determinants, particularly gender, class, caste, and education, rendering it especially severe among women who occupy structurally marginalized positions. In other words, digital exclusion often mirrors and amplifies existing norms of social exclusion. Third, evidence suggests that access to mobile phone is meaningfully associated with the adoption of certain health-promoting behaviors. Then there are certain themes which we are able to come out from our field. But before that, we have collected data from health users, which are in health wellness centers. And we are also trying to interview some healthcare professionals in Jaipur. The sample was stratified by binary gender categories, which is only focusing on male and female. And there is a limitation in terms of non-inclusion of third gender participants. So data collection by semi-structured interview and all that, analysis was conducted, and we are able to come out with these 4 themes. And these themes were further divided into health users' perspective and then professionals' perspective, what their perspective is and what other professionals' perspective is. I'm not able to going to deep into everything, that the paper is there, so we will share from that. But the one I want to discuss with the first point, that is health and healthcare belief system. If we look upon the user's perspective, which is health and wellness centers, we interviewed and we got to know that there is a difference between male point of view and female point of view. Users equate health with absence of illness, physical fitness, proactive self-care, that is diet, exercise, and tracking. mHealth apps used for preventive health, especially by urban users aiming for active lifestyles. They believe their belief system reflect medicalized behavior-driven model of health focused on physical capability. But when we interviewed some professionals' perspective, that is medical people from medical line, they mHealth tools enhance health information delivery system, especially in maternal and child health. For example, ANC reminders, nutrition tracking, and in patriarchal setting where females are not having smartphone, then male family members are often reached by mobile to ensure maternal care follow. That is another problem. Softwares like PCDS supports implementation of national schemes in Rajasthan, though focused on women's health benefits extend to broader use base. Mobile tutorials help professionals, hand-on use increase confidence in digital platforms. And when we are able to see the gender dimensions in users, where we get data from the health and wellness centers, both genders shared a clinical view of health but express it differently due to social norms. Men stress more on physical activity while women focus more on self-discipline and care. Health work, if we look upon health workers, female staff take lead in women-centered programs but report low digital access and confidence. Male staff often feel better informed and more digitally skilled. It shows genders, roles, and training shape mHealth's impact with the healthcare system. I'm concluding. Yeah. Other points I'm not going to deep, but there are some policy recommendations we are also suggesting. So promote gender responsive digital literacy through ASHA and A&M training and community-based outreach, but have to increase the incentives for both, because their incentives are so minimal. They are reporting that our workload is increasing day by day as the moment national digital health mission introduced. So they are underpaid, workload is more. So redesigning mHealth tools with women in mind, including their need in sexuality, their reproductive health, contraceptions, and mental health services. We should include structural exclusion category, which is excluded yet, like caste, class, and geography, through intersectional policy designs, ensure women's participation in technological development and leadership roles in healthcare system, regulate digital health content for accuracy, privacy, and cultural relevance. So with this, I stop here. Due to the paucity of time, I'm not able to elaborate more, but thank you so much for giving me such time. Thank you.
I invite Dr. Rashmi Kumari.
Good afternoon, everyone. So I'm going to start speaking on title of my paper, Half Truth of Sexual and Reproductive Health Among Youth in Urban Slum in Delhi. So what is sexual health, and why I'm saying youth girl? It is a half knowledge for them. So sexual health refers to physical, emotional, and psychological and social well-being in relation to sexuality, and that includes control over fertility, protection from sexuality transmitted diseases, as well as protection from sexual coercion, stigma, censorship, and violence, and the possibility of pleasurable and safe sex experience. So in that evolution of the definition of sexual health, the earliest reference to sexual health was a international conference on the population and development, ICPD program for action was first initiated this program, and that was reproductive health, that also includes sexual health, that proposed to which is the enhancement of the life and personal relation, and not merely counseling and care related to reproduction and sexuality transmitted disease. It aspect that also the part of reproductive health, that understanding the sexual health that has evolved over time through the recognition of its interconnection with diverse thematic area of human rights. So again, in the 1995 fourth conference on women and sexual health found mention as an aspect of sexuality over which women's autonomy was recognized. The human rights for women include their rights to have control over and decide freely, and responsibility on matter related to their sexuality, including sexual and reproductive health, free of coercion, discrimination, and violence. So, what are the determinants of sexual health? The material determinants of sexual health includes access to safe and portable water, adequate sanitation, food, nutrition, housing, safe and healthy working conditions and environment, health-related education and informations. It further states that people are able to have satisfying, safe sex life and that have a capability to reproduce and the freedom to decide if, when, and how often to do so. Implicit in the list, last condition that are right of men only, and women to be informed and to have access of safe, effective, affordable, and acceptable method of family planning of their choices. So the sexual health outcome are equally shaped by social determinants that refers to social norms and structures that stigmatize oppression or marginalize person or account of their sex, sexual orientation or gender identity, marital status, age, ability or caste, ethnicity, minority status. So these articulations establish that sexual health is related to sexuality, sexual relation, including but also independent of reproduction and disease prevention. That is entail the availability, accessibility, acceptability, and quality of information, of knowledge and services to enable making informed choices of satisfying and safe sex. Basically, the knowledge. Importantly, sexual health was recognized as an aspect of women's right and gender equality. Sexual and reproductive health. So, sexual and reproductive health are two distinct but partially overlapping concepts. These are not a separate part, although the two overlap to the same extent, particularly in relation to information and services relating to contraceptive use, abortion rights, and sexuality transmitted disease. The term well being as an adjunct to sexual health confirms that its domain is not limited to disease and treatment only, but includes aspects relating to autonomy and pleasure with reference to sexuality. So, as a result, vulnerability and health outcome of these population group depends considerably on legal protection against violence and discrimination. So, this is the number of my. So, yet the scope of sexual and sexual health is more expensive. The understanding of sexual health evolved significantly through linkage with HIV/AIDS also, marginalization, discrimination, particularly of sexual minority like lesbian, bisexual, transgender, and LGBTQ plus. So my study was conducted in Delhi slum area. So total 199 households were selected purposely. Major research question was what are the problem faced by urban poor girls in terms of reproductive and sexual health? What are the socio-cultural factors also that influence sexual and reproductive health? So during the pilot visit, the study area major reason for the choosing this particular area, that is Harijan Basti, was that is a very expensive was situated between the very expensive area in Delhi, South Delhi, and the urban slum is this particular place is surrounded by Delhi Development Authority flats. These are very expensive flats, and most of the people working here. No.
I think you spent a lot of time in the definition.
So these are the finding I have to say that 60% of population living in one room area, and only space of cooking, in terms of cooking, they have only 49%, for 24% saying yes, we have space of cooking. I'll show the picture of the room, which you can see there. Woman is cooking and with two children. This is the size of the room. The whole house, this is the size of the room, where we have living area, cooking area, everything is there in the same room. But they have the outdoor bathroom facility, which was on the share basis. This we can imagine how the personal health affected by this the condition. So knowledge about the fertility, we can see the table here. Married population 63%, young girls, they are saying. Also about the fertility knowledge, 43% saying no, we don't have the knowledge, and knowledge about the contraceptive pills, and they have said yes. 75% they have said yes. Other than the Anganwadi centers which I have encountered in the study area, they were saying we have comprehensive information we are giving to the this population. They have also told me if they are not following where they are if they are not following these so it is not our problem. Some married couples want to use contraceptives, but once their families found it, they are using it. The family immediately stop them. Young married girls are dependent, and even husbands are reliant. They have not listened to their parents. So this is the sexual health problem of young girls in the marital status. We can see the table. Also, so this is the discussion. We may have so many programs like Janani Suraksha Yojana and all these programs under the National Health Mission. Also, we have so many programs, but still the condition is very worse. And see, this is the overview of the room. We can see, show the room setup where rooms are attached and accessed by single doors. Here, no window, you can see. Outside space is used for water storage. And the exterior of the room illustrating how they have built. Many people live in the same building, which condition worsening during monsoon. If they are using shared bathroom, the condition we can imagine, especially they have electricity problem at the night and inadequate water problem, very frequent. Sorry? Owner. Okay. They have built it for only for the migrant people. The owner not living there. Yeah, that I have contributed in my full paper. If it is for, yeah, it is there. Why owner is not using that building particularly? Okay, as at the end, I can say the early marriage and migration adversely affect their health because most of the young girls are married early and shifted to Delhi. Their freedom and choice of living are compromised based on the income and location, especially for developing countries like India. So, where reproductive health is given special attention due to low health status of women, it is important to look at these issue comprehensively. So last point I would like to say, in the digital age, girls are increasingly drawn to physical appearances, clothes, songs, and social media, which play a significant role in diverting their attention. They tend to choose fast food over a balanced diet. Unfortunately, they often do not receive enough attention from their parents during their formative years because parents are busy with family work or job. Emotional sharing, and bonding are often missing in these families due to negligence and a lack of care. Thank you.
Yes.
Please introduce yourself. Oh, sorry.
Do you want me to wait? Sure.
Okay.
Sorry. Yeah. I'll open that. Some other one. This one. Yeah. Hello. Sorry. Yes, I'm keeping track of time. Sorry. Hi, everyone. I'm not a gender researcher. My focus is primarily from cybernetics, information systems, and complex systems, which is what I'm gonna talk about. But I'll end with gender. I identify myself as a hacktivist. I've been documenting digitization in India mostly by reverse engineering whatever the state was building. And what I'm presenting here is, sorry, there seemed to be a problem.
You can just speak your name and a line about it.
Yeah.
Oh, I think that's what he's doing.
Hello. मिरर कर दो शायद वो इसे एक्सटेंडेड चेंज करके मिरर कर दो डिस्प्लेस में एक्सटेंडेड निकाल के मिरर करो डुप्लीकेट द डिस्प्लेस नहीं एक मिनट मैं कर लूंगा या मैं कर लूंगा I'll do it yeah okay हो गया there's a PDF now yes okay sorry as I was saying my name is Srinivas Kodali I identify myself as an activist I've been reverse engineering a lot of digital systems in India especially focusing on Telangana and Hyderabad. We do happen to be one of the ground zero for digitization in India. And here I'm going to talk about India's digital ecosystems, in particular the health digital public infrastructures. So what I'm trying to present here is the 360-degree model that everyone's been using. I mean, I'm going back to COVID and the whole identity model. Everyone's been looking at Aadhaar and the ID model, but we haven't really figured out why the state's trying to do this. Where are these imaginations coming from? Most of my work has been around that. So if you go back into genealogy of digital health infrastructures in India and programs at large, Andhra Pradesh's or United Andhra Pradesh's Arogyasri happened to be one of the early public health programs where there was an extensive use of digitization. The idea with data collection was that the state would collect 360-degree profiles of everybody, healthcare or elsewhere, and share it to the insurance sector. And in doing so, it would bring down the cost of insurance. Well, Obamacare failed in US. The Andhra Pradesh bureaucrats were very much posting that Arogyasri works. Our insurance costs are so low because we're able to collect a lot of data. The Ayushman Bharat scheme at the center, PMJAY, is modeled around the Arogyasri program from United Andhra Pradesh. And you see a shift from COVID where you see the Government of India's plans of digital health ecosystem. There was a blueprint for it, which was proposed back in 2018 along with the Ayushman Bharat scheme, start getting implemented with COVID. You see Arogya Setu, CoWIN, PM Poshan. You see a bunch of these systems, but these systems are not isolated. They're very interconnected. When you talk of Arogya Setu and CoWIN, you see the vaccine certificate is being issued by CoWIN, but you get to show it in Arogya Setu, right? So these are not independent systems, they are interdependent systems. In using these systems, you're creating what they call the 360-degree health profiles, where the idea is to collect everything about everyone, right? And you see this model get replicated in every other sector apart from health. If I have to talk about this in, say, population systems, the National Population Register is an equivalent of this. You talk about policing, 360-degree policing and profile surveillance comes into play. So you're looking at one model of profiling that's being used everywhere. And this model is endless. How much ever you keep on adding data to this 360-degree model, you can add more because we can't mathematically model the universe at 100%. It'll always be 99%. Even you go reach the limits of infinity, you will still be stuck there. So what is the 360-degree model? So the 360-degree model comes from these ideas of complex systems. So complex systems, the properties of these complex systems, right? Complex systems are self-organizing. You see some of these systems popping up in nature, in ecosystems. If you've looked at Dr. Amiti's presentation of ecosystems, you find that ecosystems are self-organizing, self-regulating, right? And they're also adaptive. Whenever something changes in one ecosystem, you see that there are other interdependent ecosystems changing, adapting to those changes. And these are non-linear systems. By non-linear, I mean mathematically non-linear. There is this science called chaos theory, non-linear science, if a lot of you are familiar with science and technology studies. And these systems are interdependent. So they're not isolated, they're not individual, they're so interlinked that any changes in one system will have cascading effects in other systems. There's one more property that we look into called emergence. A lot of philosophers have been talking about it, a lot of scientists have been talking about it. These are patterns in nature that emerge. And some of the key parts of key properties in this idea is that when you interlink these independent systems, then they might have larger effects. So in this case, 1 + 1 is not 2. It can be greater than 2. So when you're linking Arogya Setu and CoWIN, you're not just having effects of Arogya Setu and CoWIN, so you're having multiple other effects beyond these individual systems. So these ideas are primarily coming from this one particular country, Estonia, which happened to have an institute for cybernetics back in USSR, back when Estonia was part of USSR. And we happened to get a lot of these ideas from Estonia, brought to Hyderabad, in particular in the 90s, where in Hyderabad, we had a lab at TCS Hyderabad called the Cybernetics Lab. And a lot of these models have been kind of imported and self-developed here within the city. Again, the properties are same. You see that the architectures are similar to an ecosystem. So one thing that I want to go back to with the 360-degree model is when you look at Arogya Setu and when you look at CoWIN, especially the certifications, they're often cited as the single source of truth, where the state is saying, unless I say that you're COVID certified, you're not technically certified. Or if Arogya Setu is saying that you were in contact with a potentially COVID positive person, then you might be COVID positive. It doesn't matter what the health report or a health test report might say. It's these information systems that are determining what is truth. But you need to understand, because these are nonlinear systems, the effects of a nonlinear systems are not linear, right? So the effects in an ecosystems are very nonlinear. So the truths, the effects of every individual are very different. How women see what's happening to them are different from men. How a Muslim individual sees effects on them are different from a Hindu or from a Dalit person, right? So truths are nonlinear. See, the state is now forcing a singular truth in a society that's very nonlinear. Yeah, so I just want to conclude. So the model, what you're witnessing with this model is that this is coming from the idea of ecosystems and nature. The science is solid, okay? But some of the scientists who are talking about this are actually accepting that what we need to do instead is we all need to have a spiritual outgrowing. We need to accept what are these problems and how do we address these nonlinear effects. But instead, and by saying that, the scientists are accepting science is not neutral. When the science itself is not neutral, technology is not neutral. And this is one of the eco-feminist thinking about science. And we need to push this idea from an eco-feminist lens and from a feminist lens, the effects of these systems, because they are non-linear, they are complex. Now, how do we address these systems? How do we redesign these systems? Can we do that? That's a question I don't have an answer to, but this is the 360-degree model out there. Just show one last slide, sorry. Yeah, I just have a repository that I maintain, which has a lot of documents that I get from Government of India through RTIs. There's a lot of health documents and other documents too, and you may reach out to me here.
You're maintaining it yourself? Or?
Yes.
You go ahead. Thank you very much. Professor Sudha Kakode.
उनके पास ये सब
इसको निकाल दें भैया
Good afternoon, everybody. I'm Professor Sudha Kokate from Department of Sociology, Bangalore University, and I'm also the chairperson of the department. Firstly, I would like to thank Professor and a good friend of mine, Professor Ziauddin, and the Dean, Professor Shahida ma'am, for organizing such a wonderful event and inviting me here to be one of the speakers among all these distinguished speakers and delegates here. And I am going to talk on women health and well-being in the digital age. We all know that the era that we live in, we all know that how technology has changed, transformed all of us. AI is working both ways, negative and positive. And I was just reading yesterday on the Forbes magazine, a doctor from Hopkins University says that, I just quote what he says. He says, fix the healthcare system. Oh, sorry. He says, AI has allowed me as a physician to be 100% present for my patients. There's another anonymous reader who reacts for it and says, fix the healthcare system, but not by permanently invading my privacy and altering my relationship with my doctors. No, you may not record me. So this is how we have been debating and talking about the use of technology and how we are making use of it. But then I would like to talk about this digital age, because I myself have experienced it, right? Yeah, I don't mind sharing my personal thing here. But I was diabetic at a very young age, right? So this was a juvenile diabetes. Off and on, I have been using a lot of digital, gadgets, which is constantly monitoring my blood pressure, which talks about my hypoglycemia, going into hypoglycemia. And that, by using all of them all over, has actually empowered me. There used to be a time when we used a lot of hypoglycemia used to happen, but then now again, thanks, where I can still monitor with one small gadget and say that what I eat, the insulin is taken from that small machine, and then it is injected into the body automatically. So somebody was telling me in the afternoon, I asked, this is double meat for lunch? They said, yes, it is double meat and you should eat double. 2 times. I said, no, I'm diabetic and I can allowed to eat only once. But that is again thanks to the machine, which takes the required insulin and then injects itself. So I don't have to worry about how much do I take and how much I do not take, right? So this, looking at the positive side of it, and looking at the brighter side of how it has managed people's life like me and others, I would say that improving women's health, right, through access of technology, it only addresses the critical medical need, but also it empowers women at a very individual level, at a community level. And then it is also trying to talk about how fostering it makes resilience, and it promotes the sustainable development of it, right? So for a long time, it does help you. It does allow you to manage your life with the help of technology. And then empowering a woman in general is also a cornerstone for all of us, as we know, for economic growth and sustainable development. And this experience has consistently demonstrated that granting women equal access to resources like healthcare and education, it benefits society as a whole, right? And then it has also enhanced productivity, and it has improved health of many women. Now, for example, if you look at India, which has the highest maternal mortality rates across the world, with 19,000 women dying during pregnancy or childbirth, and this is the record data of 2023 alone talks about it. And this constitutes approximately 7.2% of the global maternal deaths. Now, there are stakeholders from across the country, both from the public and from the private sector, who have made efforts to address this challenge, right from investment into the quality healthcare to awareness building activities and so on. So there is another a Bombay-based NGO which talks, Arman, it has helped and aimed to accelerate the progress by developing AI, and it has built a pro bono support from researchers at Google DeepMind, and it has also found indicators of success and cause for hope. So this Arman has partnered with the Ministry of Health and Family Welfare to implement Kilkari, right? And that's the world's largest mobile-based maternal health information program. And it has reached almost over 60 million women and children across 27 states and territories in India. So over the last decade, we've seen the healthcare, the improvement in the healthcare, especially during pregnancies. It has used innovative approach of delivering weekly, timely, appropriate audio messages about pregnancy given to who all are listed and gone through women, even in the rural areas. During their childbirth, and then after childbirth, that is the child care to new and the expecting mothers. So all these technologies have helped, rather in this area, have delivered via free phone calls, and starting from the trimester of pregnancy till year and after even delivery. So that's one way of using with both the private and the public combining together help women during the pregnancy period. And then there is another example which we talk about, cervical cancer, which remains another health concern in India and globally. It is the fourth most common cancer among women worldwide, with new cases estimated around 660,000, according to the data published by the World Health Organization. And then the World Health Report also states that the highest rates of cervical cancer incidence and mortality occur in low and middle income countries. So that is also creating a public health concern, a burden on a country, especially like India. So one woman dies of cervical cancer every 8 minutes in India. So according to the data published again by the ICMR, National Institute of Cancer Prevention and Research, the cervical cancer is also the second most common cancer in India. So that accounts to almost 22.86% of all cancer cases in women as per the data. So to fight and to come out of these, we need effectively early detection, which is also very important and crucial at this point. So access to timely and accurate screening continues to prove a key challenge, particularly in remote regions and underserved communities. So there is another technology, a company, Periwinkle, who also addresses these challenges and helped the women workers to, help them in the remote locations of their places to examine the cervical examinations without any need of intensive care infrastructure. But the devices of artificial intelligence capabilities have enhanced diagnostic accuracy, at least, providing immediate visual reports and enabling them with a quite prompt decision making and timely treatment. So all this goes on to say that it has contributed to the saving of many lives through timely detection and counseling. And the screening technology has been also used by gynecologist clinics, public health care providers, hospitals, NGOs, and corporate health programs. For most of our ladies, women, at least from my age, we've been talking about our period problems and the pain and everything, which was normalized by even the doctors in the society. But recently, I have two daughters. So one of my daughters said, Amma, I am in this phase of my menstrual period now. I was like, what is this? Right? We only know once in 28 days we get our periods, and this is what happens. But no, she's downloaded an app which talks about how the mood swings happen during those periods. Right? So she's like, Amma, I'm in this period now. So yeah, yes, this is the period. So this is the mood swing that I have. So I'm about to get. So I'm into this kind of a mood swing, So for a minute I was like, yes, of course I use it for my own purpose. But now even children are talking about and using about how to go about their life in a day-to-day life, and experiencing it through it. So they have become extremely sensitive here, sensitive to the extent that we never knew about it. The doctors never spoke about endometriosis then when we were there in our periods. The doctor also said, I also had the same period. It will pain, everything will go off. You just have to live with it. That was how it was normalized. Not much research was done, which is actually very shameful on the part of the society in the larger context, because if this had happened to a male, then there would have been a lot of research and a lot of money would have spent on the R&D. But it just because it happened to the women folk, and they are still struggling about the pain and everything, there's a lot to be done. And now we see doctors are trying to talk about the pain and the endometriosis, and connecting a lot of things with PCOS and everything. I hope someday we get a solution to all that, and AI will be able to, help us, not by detecting, but also I think we need to have a human touch to counsel, to pamper us, to give a love and support and care and everything. Okay, so with these few examples, I would just like to conclude and say that there is a source of also bias in this composition and teams that we see who develop AI systems. And the field of artificial intelligence is also marked by gender disparities that we see across the sections, and especially the feminists talking about it. So women are vastly underrepresented in technical roles, right? We also see them underrepresented in leadership positions and AI research itself. So this lack of diversity also limits the perspectives, and then it also tries to inform how AI models are built and evaluated. After all, if it is giving the old data, then things will not be up to date, and it cannot match up with what the woman has, the real issues of women are, and the real issues of the men are. Differentiating would be a big problem then. So this, as I said, the lack of diversity limits the perspectives that inform how AI models are built and evaluated, and it also shapes the questions that the developers think to ask, the type of data they prioritize, and the edge cases they prepare for which it can be contributed to blind spots in how tools perform across different populations. So the studies have also shown that more diverse development teams are better able to anticipate unintended consequences. And also, if you have to design systems where the performance or the equitably are equal or more accurate across the demographic groups. So if the absence of these perspectives increase, right? So the risk of overlooking the gendered impacts is always more. So I hope someday that If you look at the data collection, the model training, the system development, or the impacts on the patient, with the rapid rise of AI, we all should be able to use the AI, because bias also matters the most. So it should not help and affect the life of women, which is already at stake and underrepresented in the society. Thank you so much for giving me this opportunity.
Good evening. Good evening. My name is Nimisha, a PhD scholar at the Center for Economic and Social Studies, Hyderabad. Today, I will be presenting my research on telemedicine and women's health in India through the lens of a capability approach perspective. So this research explores the transformative potential of digital health and the profound challenges that prevent it from being a truly equitable tool. So the topic is incredibly timely, especially given the accelerated adoption of telemedicine post-COVID-19. So with the post-COVID-19 surge, programs like eSanjeevani was heralded as a key tool for achieving universal health coverage, as it claimed to be a solution to bridge long-standing rural-urban health disparities. However, this optimistic vision stands in stark contrast to the reality of gender digital exclusion on the ground. According to NSO, a staggering 51.6% of rural women aged 15 and above do not own a mobile phone. And the gap in internet use is also significant, with only 24.6% of women using the internet compared to 43.4% of men. So this reveals also a critical gap between providing technology and ensuring genuine access. It brings us to the central question of the paper. How can telemedicine move beyond being a mere technological resource to become a genuine tool for expanding the health capabilities of women in India? So to analyze this complex terrain, my research employs the capability approach as its theoretical framework, which was developed by Amartya Sen and expanded by Martha Nussbaum, helps us to critically assess the impact of digital initiatives. So my paper argues that while telemedicine has the potential to enhance women's health freedoms, this promise remains largely unrealized. Therefore, for it to be truly transformative, digital health policy must shift from a purely technocratic design to a capability-focused approach. This calls for a feminist and intersectional reimagining of digital health governance. So why the capability approach? So the capability approach is a powerful tool for this research because it moves beyond a simplistic metrics of access and usage, like how many people downloaded an app. Instead, it focuses on the freedom to achieve well-being. So its core concern is to evaluate what individuals are actually able to do and be. This is particularly useful for analyzing gendered access to telemedicine in a structurally unequal society like India because it emphasizes the conversion of resources into real opportunities. Ultimately, it provides a robust framework for assessing if digital health initiatives are truly enhancing people's life. So here, based on Martha Nussbaum's framework, 3 capabilities are especially relevant for analyzing women's health. First is life, the capability of life, which is the ability to live a full human lifespan without dying prematurely. Second is bodily health, that is, which include access to nutrition, reproductive health, and shelter. And third is bodily integrity, which involves safety, mobility, and reproductive autonomy, areas where women often face significant vulnerabilities. So scholars like Sridhar Venkatapuram also conceptualize health as a meta capability, which means it is a capability that enables individuals to achieve a range of other capabilities like education and social life. So the implication for telemedicine is clear. It must not only enhance service delivery, but also women's real freedom. This requires dismantling structural barriers through a conversion-focused policy. So coming to telemedicine in India, telemedicine actually means healthcare at a distance using ICT. So its global use dates back to the early 1900s with ECG data being transmitted over telephone lines. Initially, it was used in exceptional circumstances like disasters or wars. India's journey, its official journey began with ISRO's pilot project in 2001, linking Apollo Hospital to a rural hospital in Andhra Pradesh. However, the real turning point was COVID-19. The pandemic accelerated the adoption of telemedicine across all sectors, positioning it as a safe and scalable alternative to an in-person consultation. So, viewed through the lens of CA, these telemedicine platforms, particularly in an ideal and inclusive scenario, hold immense potential to expand women's central capabilities in meaningful and transformative way. First, enhancing life. At the most fundamental level, telemedicine can support the capability to live a full and normal human lifespan by ensuring timely diagnosis and treatment, particularly for women in remote and under rural areas. Faster access to specialists, telemedicine can prevent premature death and manage life-threatening conditions more effectively, contributing directly to women's right to survival and longevity. Enhancing bodily health. So, for a woman living in a remote village, consulting a gynecologist or a pediatrician through telemedicine eliminates the need for a long, expensive, and often unsafe travel to a distant hospital. This represents a clear expansion of the capability to be healthy. By reducing time costs, travel barriers, and opportunity costs, telemedicine enables earlier care seeking, promotes better maternal and child health outcomes, and enhances patient education by equipping women with knowledge about their condition and preventive care. Women's health concerns, especially related to sexual and reproductive health, are often wrapped in layers of stigma, shame, and social restrictions. So, telemedicine offers a private, confidential, and less intimidating space where women can safely seek advices. Other benefits are it will allow a longitudinal health records, which empowers women to actively manage their healthcare. Access to one complete medical history supports the capability of practical reason, the freedom to reflect and make informed health choices. Also, it enhances accessibility for women who are immobile and constrained by social norms for traveling alone. So, this potential, however, rests on the critical assumption that women can seamlessly access and use telemedicine. But that is not the reality. So, what are the barriers? The first set of barriers are personal barriers. Like many women, especially in rural areas, lack the digital literacy and general education needed to operate smartphones or navigate complex telemedicine apps. Also, next is the language, which is most platforms are in English or a dominant regional language, making them unusable for a large population of women who speak minority languages or are not literate in these languages. This multifaceted skills gap lead to a lack of self-confidence, making the prospect of engaging with an unfamiliar digital platform intimidating. So, what are the social and cultural barriers? Social and cultural barrier create some of the most intractable constraints. In many households, the mobile phone is not a personal asset, but a shared male-controlled device, which severely limits women's autonomy and privacy. Also, social norms discourage visible phone use by women, often associating it with inappropriateness. They are expected to use the phone for limited purpose, such as communicating with their family and not for independent health seeking. Finally, the fear of online harassment poses a genuine threat to women's safety and also serves as a justification for families to further curtail their digital freedom. Coming to the environmental economic barriers, first one is the lack of financial autonomy to own a smartphone or consistently pay for a data plan, especially those from a poorer household. Also, infrastructure deficits and trust, that is, a platform design such as a lack of patient identity verification erode trust, which is a significant barrier for women who are already vulnerable to privacy risk. So, what are the enhancing capabilities and how can telemedicine transform women capabilities? So the evidence clearly shows that digital health platforms, when designed with a universal user in mind, risk amplifying existing inequalities. To transform telemedicine into a genuine tool for equity, we must shift our focus to a gender-sensitive, context-specific, and multi-level strategy that addresses infrastructural gaps, social norms, and individual constraints simultaneously. So the first recommendation is to strengthen foundational infrastructure and access. This means prioritizing investments in rural digital infrastructure. Also, policies must ensure affordable smartphones and data plans, especially for women. Also, public-private partnership can be leveraged to scale up these initiatives, and incentives can be used to promote investment in poorly connected regions. The second recommendation is on promoting digital literacy. Also, this should include empowering frontline health workers with technology training, which will increase the trust in communities. Also, The third recommendation is to have design contextual and inclusive digital tools, that is localized content and multilingual interfaces. Also, for low literate users, the design must incorporate audio visual aids and icons. We also need to enable offline functionality and design for low bandwidth access, which is the reality in many rural areas. Next is privacy by design. So ensure platforms must guarantee privacy, safety, and trust. And next one is we must institutional inclusive governance. This means moving beyond a tokenist consultation to involve women from marginalized communities as co-creators. So building trust is key. So engaging local leaders and civil society actors as trusted intermediaries is vital. Sixth one is generating gender disaggregated evidence and policy feedback loops, so that we have to collect data to inform adaptive and responsible policy. My seventh recommendation is to leverage gender-friendly access models such as the common service centers, which can be helpful for making women more comfortable in using digital devices. And finally, it is to broaden the health policy scopes. That is, it should aim to restore and protect women's capability, not just manage illness. So to reiterate, the governance of India's digital health ecosystem must ensure the formal and empowered participation of those it is meant to serve. In conclusion, telemedicine in India stands at a critical crossroads. It can be either a powerful tool for equity or a source of deeper exclusion. So the path forwards requires a paradigm shift, a move away from simply building digital highways to ensuring that they are designed to lead to destinations of well-being, equity, and dignity for all of India's women. This demands a sustained political will to see women not as a passive recipients of technology, but as active agents in their own health journey. Thank you.
Yeah, we can be open to questions. Thank you for all your presentations. We had a fantastic session, I think, and some of the points that came out was so interesting. Especially, I specialize on maternal health. So how digitization has actually, completely changed the scenario in India about antenatal care. How these M-Health, as you said, has changed how women get these messages of when they have their antenatal care. And, as Professor Sudha was saying that, how it has empowered women, how it's empowered her. And digital technology, actually, when I have lived in Germany for 13 years of my life and 4 years in Australia. So I know that like when you go to a doctor, you register yourself, your basic data is there with your general physician. Then you go to an ENT, you tell your doctor's name and they can then derive your data from there. So, and I used to get reminders every 6 months or at least a year. I used to get reminders for pap smear and mammogram. So, and letter, through an automated letter, it will come to my postal address. So I used to do regular mammograms and pap smears every year in Germany, but after coming to India, I'm not doing it anymore. Because I got used to that system where I used to get reminded by the doctor, and if I don't go, I again get a reminder. So all these things have shown, even COVID, the example that you gave, we've done millions of people, how they were covered because of the digital technology. And, but it always comes with a pinch of salt, because we have now a system called, Gates Foundation has AI-enabled ultrasound. So it will automatically give you, the AI will do a complete ultrasound and it will give you the full genetic history of that child, male, female, everything. So that kind of data, if it is now, it is in trial in Kenya and all, and what impact it's going to have when it comes to India. Actually, I also had done a study on Vansh in India in 4 different states. I just wrote a book on that, on sex-selective abortions. And one upper class pregnant women was sitting and actually discussing that there is an app which actually counts the heartbeat of the fetus, and actually concludes whether it's a boy or a girl based on the heartbeat. That is their understanding. That they have done an analysis. They were discussing with each other, two friends, both pregnant. Oh, you know that app? Oh, that means it's a boy. Because, no, this is a mindset. So what do you do with that mindset? That's the main thing that we need to address. AI can, or digital technology can solve a lot of health problems, but how do you address, mindsets? So for that, we need a lot more work on, there was also a paper on Naila Kabir's concept of how we actually empower women, so that's where research plays a major role. So that's the gap, and technology can reach to a particular limit. Beyond that, becomes a gap of where are the marginalized of the marginalized. We need to reach everyone. So that's the positive aspect of this session. I think that AI and digital technology has its positive aspects, but how to reach everyone. Okay, and with the understanding that AI and digital technology has its drawbacks as well. Thank you very much. So, any questions? Open.
Rashmi, your topic, can you repeat, please? Yeah. Yeah. You spoke about, I think maybe the full paper may have all the information what I was searching in that. Linear table will not help for me, at least, or for others also, when it comes to knowledge of contraception. Shall we speak in Hindi या English ठीक है? हाँ, तो आपने एक टेबल बनाया था knowledge of contraception, okay? एक टेबल वो बना दिया 45-50%. The one table speaks of a linear table of education. You tell me dependent two tables, in no way it helps us. It only gives knowledge in this room, how many have knowledge, but it should go with the dependent and independent variable. Like how many educated people have the knowledge or illiterate have knowledge. Overall, 80% fine. But kisko hai, kisko nahi hai? That's very important. And what I missed is decision-making part. Like when I did my study on reproductive and sexual health and all, way back in maybe late 80s, early 90s. बहुत important है हमारे इंडिया में कि I start taking decision when I become pregnant grandmother. जब मेरी बहू भी pregnant होगी तो I start overcoming that phobia of sas, sasur, joint family and all that, because the shame factor comes out, and then I start taking decision wherein I have already contributed 10 children. I got married very early. The whole fertile period was used very positively. That time we never had that sex differential gender issues and all. Way back 20, 30, 40 years. Bache, Bhagwan liya, banda liya. So that type of thing was there. So the column of decision-making part, I felt always it came after you become a grandmother and then to pregnant. So after contributing enormously maximum of your fertile period, you enter as soon as you start your age. Yeah. तो फिर ये हमारा कैसा है पता है ना कि शुरुआत फर्टाइल पीरियड पूरा मैक्सिमम 50 साल की उम्र तक मैंने इंटरव्यू लिया था और इट वाज ह्यूज डेटा 1500 एंड ऑल दैट. तो ये देखो कि आप आई मीन योर डेटा आई डोंट नो वेदर यू हैव कलेक्टेड on decision making power, age factor, education factor, joint family, single family. Have you done that? आपने 2 linear table डाला जिससे मैं खुश नहीं हूँ. I know, but never use linear table. When you're talking about a dependency factor like fertility, it is dependent factor. It's not independent of the socio-economic standing, है ना? हमारा स्टैंड पॉइंट बहुत इंपॉर्टेंट होता है. So आपने किया होगा.
अगर सिर्फ 199 एट पर्टिकुलर प्लेस की बात की जाए तो ये थोड़ा डेटा अदर पार्ट से थोड़ा डिफरेंट हो सकता है.
बिल्कुल होगा.
यस मैम. सो इन केस ऑफ डिसीजन मेकिंग ऑल्सो इस पर्टिकुलर फील्ड एरिया का डेटा में भी वेरी फ्रॉम अदर प्लेसेस.
Definitely.
या तो आई वाज प्रेजेंट.
I'm talking about your data. Yeah. Don't compare it with any other. I'm just giving you example. बताया.
तो डेटा में डिसीजन मेकिंग बहुत ही लो देखा था मैंने. व्हेन स्पेशली व्हेन गर्ल्स आर यंग एट द एज ऑफ 19 to 24 years ऑफ एज ग्रुप, तो डिसीजन मेकिंग का बहुत लेस है बिकॉज दे आर डिपेंडेंट ऑन देयर पेरेंट्स, इन लॉज. इवन द कॉन्ट्रासेप्टिव यूज का भी डेटा है वो बहुत लो है. आई हैव ऑब्जर्व. यस मैम.
आपने अनमैरिड को भी लिया है.
Yes, ma'am.
With some intention.
Unmarried, I have encountered. Married भी encountered हुआ कि same age में married का क्या क्या वहाँ पे conditions है and unmarried का वहाँ पे क्या क्या conditions है. In case of decision making power, contraceptive use and contraceptive का knowledge basically होता क्या है. If इस बिटवीन एज ग्रुप में हम अगर देखना चाहते हैं तो उनका एक नॉलेज डेवलप हो रहा है कि नहीं हो रहा है.
Yeah, one with the premise that when I'm married, can indulge in sexual activity without marriage?
In not very openly they have talked, but peer group में अगर हम थोड़ा सा
Knowledge is differently, especially वो अलग चीज होती है. आपने सेक्सुअल और रिप्रोडक्टिव हेल्थ की बात की है तो योर बेसिक जो आपका डेटा रिस्पोंडेंट्स होते हैं उनको तो यू डिसाइड ना कि यू आर टॉकिंग अबाउट ओनली मैरिड वुमेन, वंस मैरिड और एंड फर्टाइल एज ग्रुप. ठीक है. योर पीपल या I'm sorry if I'm stopping anybody from your will to paper, but why did you not mention about Amartya Sen? Not that I'm telling you, the sperm came later. Yeah, it's very good for you.
Mention.
Yeah, the sperm only checked.
No, she said Amartya also.
Seriously, but that's a very good paper. I am expecting you to contribute it, really work on that. And I think Sheila, that was a good paper. I mean, very good. This was the course to be not for that PPT, but your idea and your presentation was wonderful. Very systematic, gradually energy, very engaged. Do it, good paper. Thank you.
Thank you for that very engaging panel. I'll be very quick. So I echo the sentiment that Professor just said. I loved your paper. It was very crisp, very well organized. Clear product development framework. We exactly knew what the paper was trying to do. I just one this minor thing about the recommendation you made about frontline workers. Right? And you train the frontline workers in digital infrastructure well, and then they will do the grassroots services. Think about this slightly more critically. If you read the definition of frontline health workers, who by the way in India are involuntary workers, who are not paid by the state. Remember, it's voluntary service that they are contributing. They are burdening the frontline healthcare workers with more and more work when we put in assumptions and policy recommendations like that. The frontline workers are already hard-pressed and are making serious demands of the state to consider their advising them. So think through some of them, but also looking at that literature on labor and questions. Professor Sudha, I think you have a much more optimistic view of digital technology than I have. I think I come from a position of a lot of skepticism. But I would like to say that given that I also work in the area of healthcare and so on and so forth, I was surprised when you said that your daughter is not talking about this mutual phase or particular phase. But clearly I understand what you're trying to say. Why are we, I think the fundamental question that I have is, when at what juncture did we become so dependent on technology to tell us about our bodily experiences? Most women who are sitting in this room, maybe not when they are 19, 20, 21, but maybe when they are 25, 30, 35, would know when they are likely to have periods, even if they have a regular period, because you learn it from your embodied experience of tender breast, or sort of breast size enlarging, of your mood changing, of sort of feeling more tired. So why this dependency on an app to communicate you about the bodily knowledge is so critical, particularly about something which is a regular feature for most, which is menstruation. I can understand about your experience of infertility, which is something you cannot decide on your own. So I think the slightly sort of word about an optimism which comes in there, and also an optimism at what cost to this young girl that you are a mother of, right? So possibly that. And to Srinivas, we follow your work very regularly on X, we very familiar. Very quickly, when you were looking at the COVID portal, and I know that you've written substantially on the COVID portal, did you get any sense of, because you said all these infrastructures are really integrated, whether it's COVID, whether it's Arogya Setu, so on and so forth. But I want to ask is there also one particular, say, company which is at the helm of these affairs, right? Is it the same developer, is it the same sort of community of technologists? Because this is something that the government has been very opaque about talking to, so very sort of opaque about talking to. So what's your sense given that you have the insider knowledge, which most of us don't have? Yeah.
Okay. I didn't get your name, sorry.
I'm Parul Mishra, I'm a faculty member at IIIT Delhi, and a medical anthropologist, tech sociologist. Yeah.
Yeah. Parul. This is
Parul.
Parul.
Parul. P-A-R-O.
Oh, Parul.
Yeah.
Okay. That's nice. My daughter's 22 and 24 and all. So every day it is very challenging for me and to keep myself updated. Right. So yesterday also she came to me. She said, I have some issue. I said, okay, work on it. Just think what are your views, then we will tell you what it has to be done. No, I'll ask ChatGPT. I said, stop using it. Stop using it. Otherwise, one day your brain will stop working. Yes, brain will stop working. Your analyzing things capacity. Though she is a TEDx speaker, she's an excellent brainy student, but they're still dependent. At times they have to use it. I really don't know as a mother where I can stop it, but the what to say, the exposure is so much, right, that I think it is inevitable today. But I'm sure and I'm hoping as a mother that this is the peer group, all friends are using it, it's all okay. But somewhere down the line, one day she will start using her own brain, her own analysis, and then being too much dependent on these gadgets and everything. Definitely. Yeah, it comes in, that's what, both the ways, either way, this way or that way. Yeah.
Uh, Thank you. So in terms of the model, right, the reason I focused on the model is that it's universal. It's just not in India. And when I link it back to how it's been coming from this particular country in Estonia, where it was primarily experimented, and then it geographically comes to Hyderabad in the 90s, right? The individuals who have been applying it in different contexts are different. I mean, it's developers, end of the day, you do need a lot of programmers to build these infrastructures. There's like a whole vast of industry that's there, right? But the ideas are being determined, like, so there is this whole context. Who is determining it, this, right? When we talk of some of these systems, when we say nature is deterministic or is technology determining things, end of the day, in the Indian context, it's society. Technology merely becomes the mediating factor, right? So while some of these technologies actually do believe that they are the ones determining things, They're not really sure whether it's economics, whether it's society. They mostly don't have this idea of what even they're building, right? Like, they know it's APIs, but they don't know that the concept of APIs are coming from these very ecological ideas of interdependentness, right? So it's like, as a society, we've never taught people philosophy of maths while teaching them maths, right? So you taught them logics, you taught them that, oh, this theorem gives you this, but you never told them how this is not neutral, how from econo-feminist perspective, the whole mathematical project by three men, Galileo, Descartes, or Newton, right? So that aspect is something often missing. And on the aspect of who are all these people, they're all men. That's the only unifying factor, I would say. You will find it everywhere. Yeah. Men. I mean, I haven't seen any women developer in the whole digital India ecosystem at all. Yeah. 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 I hope that, yeah.
Yeah. No, I want I want that scheme to be implemented throughout India.
So it's relevant. Yeah, please do. No, please do ask your question. Yeah. No, please do ask. Yeah.
I read that free bus scheme in Telangana has led more women to go to hospitals. So, do you agree with that? And if you agree with, and this scheme has to be implemented throughout India, so that many women can profit a lot.
So I do happen to be a civil engineer who worked on intelligent transportation systems. That's my background, like 10 years ago at IIT Madras. So I hope I'm qualified enough to answer that, what you're asking. I haven't done any particular research on it, but the scheme does help women get more access, more mobility. And those effects are non-linear. Okay, for younger women, it may help them go to school, they might go to parks, go to wherever they want. Okay, so in that sense, it's a very positive scheme. Okay, but as men, I think we should not decide what women should get. Right? You're not giving them the choice what they need to do. And should it be applied across India? Yes. If you give more women participation, that will happen.
Very good presentations, all of you, and especially with relation to Srinivas's. I just wanted to know, whenever you plan something, is ethics embedded into it, or just the program first and ethics later? Is it like a tail piece of it?
That's a question that I've been struggling with. Okay, as I've said, I identify myself as a hacktivist, and the question was always, is hacking the government moral? Is it okay? Am I doing a crime? Am I not? Is it important? Right? I think ethics are very a question of human behavior, right? And ethics of every individuals are different. Ethics of a Brahmin, ethics of a man, ethics of woman, ethics of different people. They're all moral principles that they form. And to me, as a society, morals are very important. I've been taught morals in school, that's the best place I've learned these. But I did realize that this idea of ethic or the ethical framework in technology or in AI is often so